Let's talk about the future. Welcome to Evergood Podcast. I'm Kristy Bird MaKieve, and we focus on healthcare education innovation. Today, we're going to be talking more about mental health care, which I'm very excited about, and especially because my friend, Dr. Risa Weisberg, who is a PhD, is going to share her thoughts on and knowledge. She has a very good knowledge of how the different mental health education pathways and what those careers look like to explain that. I'm going to actually read her intro on LinkedIn, which I think because I've known Risa since, I don't know, high school, just a few years. So I thought that this summary really describes you really well. Okay, so Chief Clinical and Scientific Officer, Digital Therapeutics, Behavioral Science, Psychologist, driving the future of digital health to boost engagement, improve outcomes, and build profitable businesses. It's pretty impressive. Is there anything you want
Thank you.
to add to that or?
Yeah, no, I mean, I think my career has really taken a number of turns, but it's really always been focused on how do we increase access and scalability of evidence-based behavioral health treatments, right? We are very fortunate that in behavioral health, we actually have a lot of treatments that have been proven to work, but not that many people actually know what these treatments are or know how to get them. And so my work's always been focused, whether it was in academics as a professor or running training programs at the VA or at the helm, in digital therapeutics companies, has really been focused on how do we get these treatments out to the people who need them.
Yes, I love that. And you're on the East Coast. I'm over here on the West Coast. About 10 years ago, had the opportunity to work at UC Davis with a new behavioral health center of excellence, really bringing together research and policy. And the fact that there was new evidence that early psychosis can be seen as young as 13, and then the research was going into earlier years as well. I just thought we got to get that into the hands of every person out there because you never know, is this a teenager who's acting out in a certain way? And is that actually a mental health condition that could be
Yeah.
treated so that they could have not, sort of prevent them going into full blown psychosis and things like that. So thank you for your work. I really
Well, thank you.
love that.
And
So
thanks
let's,
for inviting me. It's so much fun to be here with you, old
I
friend.
know.
It's great. So thank
We
you.
we might have some laughs because I think that's what we do when we're just together in person and on Zoom and whatnot. We did do some really good Zoom meetings during the pandemic as friends. We might drift into conversations about snacks. I don't know, right? Like what we do. No. So let's spend a few minutes talking about the provider shortage. And there are just so many training paths into mental health. And so I'd love to have you sort of give that overview.
Sure. I think there's so much about seeking mental health that people aren't really aware of. And one of the things is really the alphabet soup of different kinds of providers and what the difference between them is. And I think, like, even good friends and family members still sometimes ask me as a PhD licensed psychologist if I can prescribe them medication, right? So I think we haven't done a great job of making clear the different types of education pathways and what those really mean in terms of the scope of practice. So you really have your more medical types of practices, which are your training either as a psychiatrist or a psychiatric advanced practice nurse. And for both of those, the training really is very medical. And so, psychiatrists go to medical school, they get their MD or DO, just like any other type of medical doctor that you might see. Their medical school training is kind of identical to your cardiologists. What differs really is the work they do in residency. And so, obviously, for a psychiatrist, and I know you know a ton about making psychiatry residencies and what those look like, but they're spending that time really studying and getting practical experience in mental health. And it's a similar thing for advanced practice nurses. It's really that work they're doing in their practica, and work post sort of RN degree that's focused on psychiatry. Um, for the most part, because those are more medical fields, they are the folks who are prescribing pharmacotherapy or other types of medical interventions like TMS. That's really their main scope of practice. And it's a unique scope of practice in that other mental health providers really aren't able to do that. There's a couple of states and a few rare instances actually where psychologists can take some additional testing and get prescription privileges, but that's very rare. It's like New Mexico and within the Department of Defense. Um, so, in part too, because psychiatrists' time is more expensive, they really don't have a lot of time to do much psychotherapy in their practices. So they're mostly prescribing medications is really most of their work. Then you have the people who are really doing psychotherapy, and that is a blend of psychologists who are almost always PhD level to be licensed psychologists. There's some states changing that as well, which we can talk more about, and letting people get licensed as psychologists at the master's level. But mostly those are doctoral level folks who are licensed psychologists, as well as master's level licensed mental health providers who tend to be either licensed clinical social workers or licensed mental health counselors, LMHCs. And the training's really different. So, like, psychologists don't get training in, basic medical care or in-depth general biology, right? We're getting biological psychology training, but not sort of biology of all systems, as opposed to psychiatrists. Um, Psychologist training, because of these are doctoral programs, is fairly long. So it's minimum of 4 years of coursework. There's then a year of full-time clinical practice or clinical internship or residency, and that's all done before getting your doctoral degree.
Mm.
And then in order to be licensed in most states, you're then also doing at least 1 or 2 years of supervised practice after that. So the path to become a licensed psychologist is really anywhere, like the fastest possible would be 6 years. For most people, it's more like seven, could be even longer post undergrad. So it's a long pathway. Um, for a master's degree, folks, whether it's an LMHC or an LICSW, you're doing about 2 years of graduate school. And then at the end of that, um, getting about 2 or 3 years of supervised clinical practice before you can sit for your license. So that's more like a 4 or 5 year path until you're fully independently licensed. Um, in part, the training there is really different because you're only in school for 2 years in those master's level programs, and you're not getting a doctorate degree. Your coursework is really focused on different types of counseling, theories of counseling, assessment of mental health problems. It's very practically focused. Psychology is much more scientifically based. It's really the science of the mind. And so the degree is based around that. And so you're doing a lot of education during those 4 years of graduate school on behavioral science, science of animal behavior, basic cognitive science, basic neurobiology, and also really a lot of training on research methods and statistics and how to be a scientist. And so the training looks a little bit different. And though it includes all the training also on theories of counseling and different types of therapeutic experiences, it has this background in science going into that.
Thank you for that. I learned a ton too. And as you know, I'm currently working with folks in the Santa Cruz, Monterey area to just talk about more medical education there. and just diving into the fact that you could have a PhD in psychology that is research, but not necessarily preparing people to go into clinical practice. And I was surprised by that, but very much a part of all of it that's needed. And I don't know what would you say is an ideal team? I mean, this is really talking about maybe something to strive for in the future. I'm sure these teams exist in the country, but that it does seem that mental and physical health are very divided. And so, just experiences of trying to go to a primary care physician to get the mental health needs of a family member met, and sort of ending up in a sort of spin cycle because, it's all divided and not people working together as a team for this one patient, right?
Yeah, for sure.
Yeah.
Yeah, and there's really been a tradition of keeping those things separate, and some of it has been um, mental health providers really having this focus on the privacy and confidentiality of their patients in a way that is a little bit different than and a little bit more extreme, quite honestly, than I think the way cardiologists or primary care docs really view the privacy and confidentiality of their patients. And so sometimes even working within a closed healthcare system, like when I worked within hospitals, the behavioral health notes were locked even to
Uh,
the medical providers. And if you wanted a medical provider to be able to read your note, you had to unlock it specifically for them. Whereas they could read everybody's, the primary care doc could easily read the dermatologist notes, but if they
right.
wanted to read my behavioral health notes, I had to send a special thing to unlock that. And so a lot of the work that I've been doing for years at Brown and continue to in some other settings has really been on primary care behavioral health integration. I do think that that needs to happen more fully for most people. And sometimes that looks like, the work we were doing in Rhode Island was really trying to expand the degree to which behavioral health providers were embedded within primary care practices. And I know you've had work within Kaiser and folks out in California who were really the kind of groundbreakers in that area for implementing primary care behavioral health integration with people really co-located and embedded in the practices. But I think there also just needs to be better communication even between systems if they're not embedded, right?
Yeah.
And a lot of the psychologists that I work with never really send their notes or get in touch with their patients' primary care docs, which I find kind of an interesting thing. I can't imagine seeing patients for something like anxiety disorder and not wanting to talk to their primary care provider about, what are you doing for their anxiety? How do you see this? Can we rule out any medical factors? And helping them kind of understand and integrate a treatment plan. And so, like, yeah, I think the focus on privacy has somehow gotten folks away from that when clearly with assigned release of information, most patients want you to be communicating with their other providers. They know that that's going to lead to more, cohesive care and really want that.
Yeah. And then, of course, our friend Laura is in that space as well, and newborns. Yeah,
Yeah. It's great how we all wound up
I
doing things
know.
that really overlap. Yeah.
It's pretty cool. So the healthcare workforce shortages are happening across the country, and this is what motivates me to do this podcast. Like, what do we need to do now to ensure that we have enough providers? And I'm not just being selfish because I live for another 30, 40 years maybe and want to make sure that I have a doctor I can talk to or get the therapy I need as I age, which I'm sure I will need. So, like, what what is what do we need to know now to understand the shortages that are happening now and then anticipating the needs of the future for mental health?
Yeah.
That's
Great
a big question.
questions. Yeah, we've always had a shortage of behavioral health providers. There's really never been enough mental and behavioral health providers to meet the need. That was the case kind of always. Things have gotten worse post-pandemic, both with combination of some providers, more really medical providers, MDs leaving the field. Um, we're actually seeing a little bit of a difference in master's level counselors with more people recently entering the field because the pandemic got a lot of people talking about their mental health in ways that people really hadn't been before. People became much more open about those types of discussions and about what goes into keeping your mental health okay in times of crises. And so we actually have seen some upticks in people entering master's level programs and certainly in applications for both master's and doctoral level programs. We've seen upticks since the pandemic with more folks applying and wanting to do that kind of work. But it hasn't really led to a huge difference in the number of licensed providers yet, and we can talk a little bit more about why that's the case. But there's definitely national shortages in all of those areas now, as well as predicted, in the future. Um, in and it really varies by state and by area of the state. I know you're really
Mm,
interested in rural health, and we definitely
yeah.
see huge differences there. So, Massachusetts, where I sit, actually happens to have the most mental health providers per capita of any other place in the country. And there's about 760 providers for every 100,000 people who live in Massachusetts, which means about one provider for every 714 people. I'm sorry, one provider for every 130 people, which isn't horrible, right?
Yeah.
Caseloads, not all 130 people in Massachusetts are going to need treatment at the same time. And caseloads can probably seem like they would cover that. Whereas in Alabama, we only have about one provider for every 714 people. And
Oof.
so, yeah, really big differences by state. And those providers, those numbers are really for all providers. So that includes psychiatrists, nurses, psychologists, counselors, the whole gamut. When we look at just psychologists, the numbers are much smaller. So here in
Mm,
Massachusetts, even though we've got, you know, one mental health provider for every 130 people, we really only have one psychologist for every 1,200 people. So far fewer. And in some states, there's really almost no psychologists at all. So like the whole state of Wyoming only has about 350 psychologists. I think Alaska has single digits actually of psychologists in the whole
yeah.
state. Um, and so there really are these deserts for that kind of work. There was a movement that was in place a little bit before the pandemic, but that's really taken, spread to more states recently, which is called PsyPact. And PsyPact gives people the authority to practice telehealth across
Mm,
jurisdictions. And so if you are located in the SIPAC state, so I practice actually in both Massachusetts and Rhode Island. Massachusetts is not part of SIPAC, but Rhode Island is. So when I sit in my Rhode Island office through the SIPAC authority that I have, I can actually see patients who are in rural areas of other states via telehealth. If I only had an office in Massachusetts, I would not be able to do that. Interestingly, California, where you sit, is not part of SIPAC. New York is not part of SIPAC. So it seems to be most of the states are, but a lot of the states that actually have a more density of mental health providers are not part of SIPAC, I think, because they don't necessarily feel the need for their individual population. Um, but there is the ability to see patients across state lines via telehealth that's helping some of those more rural areas and some of the areas where we have kind of mental health deserts to get better care.
that just blows my mind a little bit. Like, well, we're good in New York, but right, the state lines are arbitrarily man-made, and so you could actually have a town right across the border in another state that does need that help, right? So it's very
Yeah.
interesting how
What
we've
makes it hard a
stitched
little
it all
bit, right,
together.
is that, I think when the licensing boards are thinking about this to some degree, they're thinking about the population of patients in their state, right? And New York, California, Massachusetts may feel like that we don't actually need that here because our patients, there's enough people to take care of our patients here. But the problem is that if the only states in SciPact are states that don't have a lot of psychologists to begin with, then it's harder to get the
Yeah.
care to the people in those states, right? Where like a state like Massachusetts that maybe has a surplus even could be providing care to other states. So we'll see what happens. A lot of the states, Massachusetts actually currently has a bill under review right now to join SciPact. So we'll see.
Fingers crossed. Sometimes we don't quite make sense in the things that we build, right? So, and that you mentioned Wyoming, and I happen to know that there is no medical school in Wyoming either.
Right.
So there's some friends who are at Stanford that looking into that. So maybe I'll send them a note and say, hey, let's talk about psychology too.
Love it.
So can you share your thoughts on access to evidence-based psychosocial treatments, psychotherapy, as opposed to just access to counseling in general? I think you actually have touched on this a little bit, but I think from an individual's point of view, or maybe a community, like really thinking about the access that they are able to bring to people.
Sure, it's such a good question, and really been an area of focus for me throughout my career, which is that I think very few people really understand the difference in types of counseling and in what good counseling or good psychotherapy looks like. Um, if you go to a new surgeon or cardiologist, you're likely to evaluate them by, how many procedures of have they done and whether there are, outcome rates for those procedures, right, before you kind of decide to pick who you're going to see. If you're a well-informed health consumer. But even well-informed health consumers of mental health care often don't know what they're looking for. And the most common question I think people ask after you've seen a new psychotherapist or counselor, if you tell people that you've been through that treatment, people say, "Oh, did you like them? Were they nice?"
Mm,
And
right.
right, as if that's the, main way to tell that you're getting good therapy. And really, nobody cares too much if their surgeon is nice. Um, and so certainly we don't want to talk to someone that we don't think is nice and don't feel a connection to. That's important. But that's sort of like the bottom base of what you should be looking for.
Right.
There really are a number of psychotherapies that have been proven to work in randomized clinical trials. So the same kind of studies that other, healthcare or medical procedures have been put through to test their efficacy, that pharmacotherapies are put through to test their efficacy. There have been tons of randomized clinical trials on certain types of behavioral treatments or cognitive treatments for certain types of mental and emotional health problems that have been shown to work. And access to those is much harder to find, in part because people don't know what they're looking for, and in part due to training shortages. So even though we're training more people, we're not necessarily training them on how to do evidence-based care. So for a while, really, there were only very specific training programs that were focused on cognitive behavioral therapy and other evidence-based treatments. Now that's much better. Almost all counseling programs of any kind, either at the master's level or PhD psychology programs, do include some focus on training in evidence-based care, which is great. But the degree to which that is like the main focus of the treatment that they learn versus just one of many treatments that they learn really varies by program.
Gotcha. Yeah.
We also see, like in these more science-based PhD programs, you're not just learning the techniques, you're not just getting a cognitive behavioral manual and learning how to do what's in the manual. You're spending years studying behavioral science, cognitive science, so you understand what's in those manuals in the context of the mechanisms of action and the science behind them and what they're doing. And I firmly believe that that kind of context for your understanding makes you more likely to actually do those treatments after you leave school, after you leave your supervised training, and you're independently licensed and you can kind of do whatever you want. So we see data showing that most people providing psychotherapy in the US are actually not providing evidence-based care. One of the best examples is exposure therapy for anxiety disorders. This has probably the most evidence behind it of any kind of cognitive or behavioral treatment. Very clear that if you have an anxiety disorder, the type of treatment you probably want to ask for and receive is exposure therapy. And yet, it's been found that only about 10 to 14% of licensed therapists in the US are giving exposure therapy on a regular basis to their anxiety patients. Psychologists are more likely to do that. Like 25, 30 to 40% of psychologists say they regularly do that, as compared to only about 10% to 20% of master's level clinicians. So twice the rate for psychologists versus master's level, but still low. And there's lots of reasons for that. And some of it is, there's been a number of qualitative studies asking folks about it. And a lot of master level clinicians in particular point to the fact that they just didn't feel like they had enough training in the area. They didn't feel really confident that
Oh,
they could do this well.
right.
Um, there's also reluctance, you know, if people are judging their therapist by whether or not they're nice,
Yes.
exposure therapy isn't nice. You can be very nice when you're delivering it, but it feels harsh to some therapists. Like you're asking people to go out and do the things they've been avoiding doing and that they're afraid to do. And so I think there's hesitancy when you haven't had years of supervised experience doing this. There's a fear that your patients are not going to want to do it or are going to drop out when you ask them to do these kind of things. There's also no financial impetus. When you are on a insurance panel and you're taking insurance for the psychotherapy that you give, the different CPT codes in psychotherapy are based on the amount of time you're spending with the patient and
Ah,
whether it was individual, couples, or group.
interesting.
Yeah, they're not asking really for the technique that you used. So you can bill just as much money for 50 minutes of kind, engaging,
Sort
supportive
of.
therapy, yeah, as 50 minutes
Yeah.
of working really hard for you and your patients and kind of planning a hierarchy of different things they're afraid to do and a mechanism for how they're going to go out and do those things and doing more evidence-based treatment. So there isn't a huge impetus. So I think
Mm.
a lot of that makes it really hard to increase the uptake of access to good evidence-based care. Um, it's honestly one of the reasons that a lot of my work has turned to digital therapeutics and digital care.
Right. Which we want to talk about next. And thank you for that. I just want to pause and say that
Sure.
you are a leading expert in anxiety. Um, did I say that right? Doesn't that sound like you have
Sure, that sounds
anxiety,
great.
which
Well,
well, you've written a book or
who
something.
doesn't? Who doesn't have anxiety?
Um, well, that's true, right? I do think it's quite common, and as somebody who's been to different therapists throughout most of my life, I feel like, yeah, you're right. Like, if I'm going to be challenged too much to get out of my comfort zone, I'm not, how much motivation will I have to really keep talking to that therapist, right? I mean, like, it is both seeking comfort by going to a therapist, but also, the real work that I need to do on myself. But I actually really did enjoy CBT. I'll say that. Okay, so let's talk about the future of mental health care delivery and the work that you're doing in that research space, because it's pretty cool and it sounds really futuristic to me.
So so part of why I started looking at digital therapeutics and digital care for mental health problems is this issue of access to evidence-based treatments. And what I like about digital treatments is that we can really standardize them. So you can build a treatment based on evidence-based treatments then you can go out and test that treatment, right? If it's delivered in a very standardized way, you can run clinical trials where you're testing that treatment and how in the sort of way it's always delivered, prove then that that is effective, and then deliver it with great fidelity because it's a digital treatment, right? It's not something that's going to be in the hands of humans who can say, like, oh, today seems like a hard day. I don't really want to work as hard. Or my patient wants to talk about something completely different today. I'm not going to deliver this type of care today. And so it hugely expands, it has a potential anyway, to hugely expand access to
Yeah.
these evidence-based types of treatments. But just like we've made understanding the different types of mental health providers confusing, there's a real sea of different kinds of treatments. Within the digital space, there's really two main branches. So there's digital therapeutics, and those are interventions that are created to treat or assess a very specific type or types of mental health or behavioral health problem, and they've gone through the same kind of testing really as a pharmaceutical, and they are FDA regulated. So they're FDA approved or FDA cleared as being an effective treatment. That's what digital therapeutics are.
Okay.
Then there's these wellness apps, right? And wellness apps are created and to be something that doesn't really treat a mental or behavioral health problem, but kind of gives you some tools to help you live better with that problem. And those do not need to go through any kind of rigorous testing. They don't really get the same oversight by FDA. They are able to kind of do whatever they're doing as long as they aren't making marketing claims that they're treating a problem, right? FDA comes into play when you're marketing as this thing, this device, this software, this app treats a
Right.
medical problem or a mental health problem, not if you say, like, oh, this helps you feel better at night, right? And so helping people kind of sort through those differences can be really tricky. There's a lot of great wellness apps out there that I think are really like doing amazing jobs. I use some myself, Calm, Headspace for
Oh, yeah.
meditation. Yeah, right. I think they're great. But those aren't intended to treat a disorder. And then there's a handful of FDA cleared or approved devices that have gone through the whole process. And like the companies that I was working for, we were developing digital therapeutics. I was bringing those things through the scientific process and the FDA process for a range of different types of mental and behavioral health problems. We're actually building our treatments in virtual reality, but there's a couple of other companies doing that in virtual reality. There's a ton doing it in more flat screen phone apps. And there's some already out there. So like there's a treatment called Rejoin for depression that's FDA approved. Daylight for anxiety. The same company has a treatment for insomnia called Sleepio. There's VR treatments for chronic pain reliever. So there's lots of these that have really gone through that FDA process. I won't say lots. There's a handful, but there's companies really working on bringing more of those through that process. Getting them is still tricky. And a lot of that has to do with reimbursement. And that's a whole other conversation that we can have possibly at some time. Um,
So you just
but
listed a bunch that I'd never heard of, and I feel like I'm out there looking at stuff, but yeah.
yeah, they typically the FDA approved digital interventions need to be prescribed by some type of licensed healthcare or mental health care provider. So the companies who have gotten these products through the FDA, then have the task before them to educate providers on how to prescribe these, and then have the task of how are they getting reimbursed for these interventions because um, not all insurance companies are yet also covering those. So there's a recent passage of a bill from CMS though that Medicare has to cover a digital therapeutic if it has gotten FDA approval, which is great, but the pricing of those has not yet come out. And so it's going to be a business question to see if the amount they're covering them at covers the expensive costs of developing these things and getting them through these large scale clinical trials. So
If they're only going
more
to get
more to be
reimbursed
seen there.
$10 for one treatment and it costs $100 to, they're
Exactly,
not gonna,
exactly.
it's not gonna go through. So,
Exactly. And a lot of, there have been a number of companies that have folded, like great treatments that are FDA approved, but folded, like Paratherapeutics is one of the best known cases. They had treatments for substance abuse and also for insomnia that were FDA approved. But digital therapeutics companies tend to be a lot smaller than pharmaceutical companies, and yet go they need to go through, and they should need to go through the same kind of standardized large scale clinical trials to prove their efficacy in order to be FDA approved. But that costs millions of dollars
yeah.
often. Some companies have found ways to do it for hundreds of thousands, but like it's never going to be much cheaper than that. And so you're building that and spending that money based on the idea that reimbursement will come and it will cover those costs. And then that hasn't really happened yet.
Yeah.
But I
Thank
think
you
there's a
for,
lot of potential there to see
yeah.
that happen for sure.
I mean,
Um,
just being able to go to your primary care doc and say, I'm having some anxiety, and then they can, prescribe something, or I'm, having a hard time sleeping. Sleepio might help, but like it seems
exactly.
like it could really help a lot more people, and not have to like go to the primary care doctor, get a referral to the therapist, go to, make the appointment for the therapist. Some of those things can take months. I'm dealing with that, not necessarily mental health with my parents, but physical health. It's
Yeah,
just taking months to get them in to talk to their doctor, their primary care doctor. So,
absolutely. And I think there's also for some mental health providers some fear that like these digital tools are going to put us out of work, and that's obviously, well, I won't say obviously, some people really believe this, but I really don't think that's the case. There is such a shortage. We need expanded access. And I also think that most of these digital tools are not going to provide enough care for people who are, more moderate to severe in their symptomatology. Um, they may, but they may not. And but a lot of people who seek care, I think, could possibly in like a stepped care way, ideally through your primary care provider,
right.
right? Get
Yeah.
these kind of treatments first, and they may be all you need. And then you can kind of step up to care that's more intensive with the human delivered therapist. For the people who really need that, more of a triaging system, which I think we need because we just don't have enough providers.
Right. Yeah, I don't think anybody's going to be replacing. Well, and I say this about all things, right? Like AI is going to replace blah, blah, blah. Everything is going to need the human and the machine, right? It's kind of like the building of airplanes. I did a case study in the MBA program where, there was this movement to, well, there's so much human error in flying that we need to go to the computers to run the planes. But then it became, well, we need both. We need the humans and the planes working together to have safe aviation. So
Completely,
it's
yes.
the
Good
same
analogy.
analogy for all of this. And honestly, I think if you're a primary care doctor and you've stepped into the behavioral health space a little bit more, you're still not going to have the time to really deliver therapy. Like, right? It's
Okay.
going to be a necessary referral at some point for most people.
Absolutely. Yeah, you mentioned AI, and we really didn't talk about that at
Talk
all. So
about
I
it.
think, yeah, I think we should because everybody's talking about it. Um, and there have been some really highly publicized, horrible examples of like general AI chatbots um, being, held and now legally in the courts potentially liable for suicides, a murder, a combination of homicide suicide case, some really horrible examples. We'll see how they actually wind up playing out in the courts. But I think everyone's attention is on this, obviously on this, and the fear that people are using more general types of chatbots like ChatGPT or Claude, for example, as therapists. And we see data saying that a lot of people actually are. About a third of Americans in a recent survey said that they are
That
using a
many?
chatbot. They're using a chatbot for support, emotional support at least. Maybe not as a therapist per se, but they've been asking, for some emotional support from a chatbot. And so, you can imagine that for some people that's fine, and that's maybe all they need is some emotional support. But for people who, having more serious problems, there's lots of examples of this kind of going off the rails. Again, we can talk more about the specifics of how that happens, but generative AI is built in part, most of these models, to reinforce the things that you're saying. And so, if you're telling it that you have a problem because the FBI is after you, and what should you do? It will give you information about, you know, cases in which the FBI is looking for people and who they're looking for and how the FBI tends to do this, right? It often won't think to ask you, on what basis of reality are you putting the idea that the FBI is after you, right? And so it can really enforce some psychotic delusions in people as well. Like, so it's a very tricky thing to try to understand how they're going to put more guardrails on this and regulate it. I know that, large companies, OpenAI and Anthropic, are trying to do this and they're setting up more guardrails, but it'll be interesting to see how
Yeah.
that really works, because the very nature of how Gen AI
Yeah.
works is going to be tricky to do this. There are also companies that are very specifically trying to create AI chatbot therapists, and that's different than like ChatGPT was not meant for this, and
Yeah, no, it was not.
CEO of OpenAI has clearly said, like, please don't use it for this. Like, that's not what it was made to do. But there are companies that are specifically attempting to make AI therapists. And there's one actually on the market right now that you can download yourself. It's called Ash from Slingshot AI, and they are marketing it as an AI therapist. Um, and that has led to a lot of controversy in the field. It's been tested with more careful guardrails and
Yeah.
a more careful, prompt engineering, because it was prompted to and taught how to be a therapist, right? Which ChatGPT wasn't specifically taught to do. Um, but there's lots of concern, and so some states have actually put in um, place some laws against this. So, like Illinois, for example, has a law banning any AI chatbot from representing itself as a clinician or therapist. And so, though you can download Ash on your phone in California or here in Massachusetts, you can't get it if you're in Illinois. It's just blocked. And there's some other states that have some regulation in front of them to look at similar things. Like California actually has a new bill that's aimed at trying to stop AI companies from impersonating clinicians of any kind. And FDA is having a meeting in November. And actually, I think it's an open meeting that anyone can join to listen in on, about the risks and benefits of AI and its use in mental health care. There's a scurry of regulatory
Mhm.
groups trying to figure out how to make this work, but right now it's a little bit unclear.
And it doesn't have to go through a clinical trial.
Well, if you're not saying that you are
Ah,
right, that you're a treatment for a particular disorder, if you're just
mhm.
supportive, you're a wellness app, and so you don't need to go through a clinical trial, and you're not FDA approved. Certainly, ChatGPT doesn't have to go through a clinical trial because it's not even saying that it's a wellness app. Like, they're saying, don't use it this way at all. So that's sort of how FDA regulates mostly the marketing of therapeutics, whether those are pills or devices, right? It's what you can claim in your marketing. Can you claim this is an effective treatment? And so as long as you're not saying that, they don't really have jurisdiction over it. And so it's a murky area to try to figure out. I think there are some great companies working on how to use Gen AI within their systems, either of telehealth. So
Oh,
there's oversight,
yeah.
like it's that first level. It's a counselor you can chat to at 2 a.m., but then a human counselor is looking over those feeds and is providing you support once a week during the daytime, right? So kind of building in the human, as you were saying before, like with the airplane analogy, right? That it's a combination of human and AI oversight. There's some companies, a lot of companies actually doing that work now, like Lyra Health, which is a large platform for human delivered therapy, just rolled out their AI companion, right? But they haven't gotten rid of the human therapist too. And a number of companies are doing that type of thing. There's also some digital therapeutics companies that use AI as part of their interventions, but these and have FDA approval and have some AI in their system, but
Yeah.
not as a chatbot. So we'll have to see where that kind of goes. But yeah.
Yeah, interesting to just, and it just all suddenly seemed to pop up, and it is everywhere. I have found myself, so the navigation in Apple CarPlay is so nice. Or like, oh no, it's Siri when I'm like, text so and so, and then what do you want to say? And then I tell them, and then they say, do you want me to send? And I say yes, right? And it says, okay, send. And I say thank you. And they're like, you're welcome. And it's like so nice. So that's my
I
only foray into it.
I agree. I mean, I use AI every day in most of the work that I do in different ways, right? And I think a lot of people are using AI every day and don't some people don't even know they are, right? Like when you're chatting with Siri, people don't always think of the fact that they're using AI. But this idea of using these systems to deliver mental health interventions is one that definitely is newer. And I think there's promise. I think companies that are specifically attempting to do that, unlike companies that are just building more general structures, and hopefully potentially go through the right kinds of guardrails and testing and prompt engineering to get something that feels relatively safe. But how it's going to be regulated is curious. There's actually a lot of conversation. There was a recent article. Now I can't remember if it was New York Times or Wall Street Journal. My apologies to those publications, but proposing that if you're gonna develop a Gen AI therapist, that it shouldn't go through FDA regulations. It should actually have to get licensed, because you just said
Ah,
it's a therapist, right? And
right.
it should, I'm sure it could pass a pen and paper licensing exam, right? That wouldn't be all that hard to do. Oh no, it was Harvard Business Review. That's who it was. I finally remembered who put, yeah. Um, it- but
Yeah, license.
should they have to have 2 years of supervised training? Maybe, right? Maybe they should have to see patients with a human supervising every single thing that they've said for 2 years and then they get licensed, right? I don't know. It's kind of an interesting idea.
It is. Well, the future is going to be interesting to see how that plays out. In being mindful of time, I know you're also very busy. My last question would really be, what would you say to individuals who are interested in pursuing a career in psychology or mental health in any way?
Yeah, I think first, if you're looking to get trained, right, and eventually get your license to deliver counseling, I think you first need to figure out what you really want from the degree. So, are you hoping mostly to be a therapist, or are you also hoping to potentially teach or do research or do other types of activities with it? Um, and I say that because the master's level routes, whether that's a licensed mental health counselor or a licensed social worker, are not only shorter, but they are, and in part by being shorter, they're less expensive. potentially, but they also are easier to get into. They're not super easy, but they're easier to get into those kind of programs. So psychology PhD programs. So there's two types of doctorate programs actually in psychology. There's a PhD and then there's something called a PsyD. PhD programs tend to be much more research based. PsyD programs are less research based and more clinically based. Overall, there are some exceptions to that, but overall, that's the case. PhD programs, the acceptance rate is nationally about 5 to 6% of applicants get into
Oof.
any PhD program in the country. And like the best programs in the country, like at Boston University or UCLA, are around 1% of applicants that they're accepting. So it is really, really hard to get into these programs. It's much easier to get into a PsyD program. They take about 40% of applicants. And a lot of that has to do with the way those programs are funded. So PsyD programs, you tend to be paying your way, you're paying your full tuition, and that's how the programs are funded. So it's something to be careful of. Like 4 years of PsyD, you're running up enormous expenses. And sometimes at the end of those programs, you have a harder time getting into APA approved internships and fellowship programs. Not always. Some of those programs are excellent and have a good history of getting their students into those, but you really need to be buyer beware for some of those companies and those programs, because you could potentially spend a ton of money to get this degree that you then still are struggling to get licensed because you couldn't get into an internship program for. So very, like, you really need to be careful about that. PhD programs take fewer people in part because you do not tend to pay as a student, because you're funded mostly through the research. And so you come in really only if a research professor in that program has space on one of their research grants for a research assistant, and they're bringing you in. They're usually giving you a stipend that covers all of your tuition and some living expenses as well, and in exchange, you're working in their lab on their programs.
Mhm.
That's just there's less money there, right? So they can bring in fewer people. And right now, we're at a place where my fear is this is going to get even more competitive and harder because we're seeing such a cut to NIH funding and to research funding and just cuts to university funding overall. And so if it was, 5% of people getting in last year, my guess is we're going to see even lower rates in the future because there's going to be fewer open slots. So if you're interested in doing that, I
Yeah.
still hugely encourage it. I love that I got this degree. It's been a wonderful career for me. But
Yeah.
just being aware that you're up against something kind of tricky, and being aware of those. There's ways that you can increase your odds of getting in. Obviously when something's that competitive, like your undergraduate GPA, and if not all schools still care about the GRE, but the ones who do, like those test scores are going to really matter. So, you really have had to have shown like good academic prowess throughout your career. But then really importantly is do some volunteer work
Mm.
in a research professor's lab during undergrad, or when you get out of undergrad, get back in touch with a research professor and see if you can volunteer in their lab. That means a ton in applications, both in terms of showing that you have that experience, maybe building out your vita, like maybe actually being on a couple of publications or research posters. But also, it's a really small field. We've just talked about how few psychologists there are. And so, if you've worked with a well known professor, and most professors in this field know each other because there aren't that many of us. If you've worked with someone and they really like you, you're in that network, and a recommendation from them is going to mean a lot more than just a general recommendation from another type of professor in your undergrad career. So, those things can really help you get in.
Thank you for that. Really good tips. Yeah, I do worry, like, right? This is all about preparing for the future and having the healthcare workforce needs met. And restricting funding for research is actually going to uh, reduce the amount of provider. It's just, yeah, it very worrisome. So,
Yeah.
uh, well, is there anything else that you want to share? Are we Good. This was really fun for me.
I think we're good. It's so much fun just to see you. And, I feel like sometimes we talk about professional things when we get together, but not that often. So it's just really fun. And it's fun to kind of get a glimpse into your world this way, too. So thank you so much.
Thanks, Risa. We'll talk to you soon.
Okay, take care, Christy. Bye
Thank
now.
you. Bye.
Lost my sense of humor, I found them too fun to know. Overgrass, blow up kayaks would have helped with angry toes, but it gave mashed potatoes. Take that meatloaf back, hi! Birthday dehydrated cake and lots of wine, so nice with clean dark hair. I think it's a waltz, I think it's a waltz, but I know it's the longest 2 miles of her. I think it's a waltz, I think it's a waltz, but I know it's the longest 2 miles of her.